It is my great pleasure this morning to introduce Tonja Santos. She is going to be speaking this morning, as you can see, on racial disparities in maternal health. This is an incredibly important issue. As you've seen, there's been a lot of attention to it across the country, and recently we've been able to see some information at our own institution that helps us to know where there's real opportunity to make a difference. And this is something I really want us to focus on, not just in obstetrics, also in gynecology. So Tonja has been at Baystate for 15 years. She is the assistant director of the division of midwifery, has been so for the last 10 years. She's an active faculty member of the midwifery education program. She's got a longstanding interest in quality improvement, been peer review committees, presented nationally on quality assurance and improvement for midwifery practices. She recently published an article on hypertensive disorders for pregnancy and implications for primary care. So she began to take a notice in that there was a difference in outcomes based on race alone, separate from socioeconomic factors, et cetera. And I think she came to the realization that something she was passionate about, and she was willing to take the lead. So I'm going to turn it over to you, Tonja. Thank you so much for doing this work. We appreciate it, and look forward to hearing your talk.
Great. Thanks so much, Heather. And thank you everyone for being here this morning for this really important topic. A special thanks to the people who typically attend Grand Rounds. So lots of our inpatient nurses and our staff that we work with in the outpatient setting, nurses and MAs and support staff. So thank you everyone for being here at this very early hour for lots of us. So originally this talk was slated to happen in March of 2020, and then COVID happened. Initially that was a frustrating phenomenon for me, but as time has passed, I've realized that there are lots of advantages to having had this forced delay. Firstly, we are in a place where I feel like we're much more open-minded and able to think outside the box, which is what we're going to need in order to tackle this long-standing problem of racial disparities in maternal health. Secondly, this pandemic has allowed us to watch what happens when disease and racism come together in real time. Black Americans in the US have 8 times the COVID infection rate and 9 times the death rate. And as you'll see, a lot of these phenomenon that I'm going to talk about this morning transcend poverty level, education level, and lots of the other variables that we typically use to explain these phenomenon. And thirdly, I think as a country, we're in a much different place in terms of our awareness of racism. Many people, especially people of color, have known for a long time that racism and bias is alive and well. But over the last 6 months, we've watched racial bias unfold in undeniable ways before our eyes, and I think it's put us in a different place and hopefully more ready to tackle the issue of racism in our country. And not to be all doom and gloom, I think the other thing that's come out of this last 6 months is I'm really heartened to see our passion and our spirit for justice is also alive and well. So the racism that set the stage for the last several hundred years for the racial disparities that we see today isn't our fault, but acknowledging it and doing what we can to combat its effects is our responsibility. At the same time, it's important to acknowledge that what took hundreds of years to set up will take a long time to dismantle and will never happen unless we acknowledge and attack the true causes of these disparities, which is racism and other forms of bias. So in terms of attendance credit and we too, labor and delivery and Weston 2 nurses, please email your manager and let them know you attended and complete a variance in order to get credit for today. And for those who are accustomed to going through the CME system, please text the attendance code, which is PUTCAM, to 413-200-2444. I'll put that up again at the end of the talk for those who are late or for those of you who find a pen fast enough. So initially, I'll start with a few disclosures. The first one is that I am not an expert in this area. But like many of you, I've watched the headlines and heard the stories and felt largely helpless with the huge disparities we see in healthcare, and especially in maternal health. But I've come to a place in my life, in my career, where I'm not willing to let not knowing all the answers stop me. The second disclosure is that I'm a Black woman. I think you all know this for the most part, and I'm also a mother. I have 2 Black daughters, and I have a vested interest in this issue. If they ever choose to become mothers, I want them to know that if they have an ectopic pregnancy, they are as likely to keep their tubes as any white woman. If they have GYN cancers, I want them to know that they'll have the same chances of survival as a white woman. And if they have babies, I want them to know that they have the same chance of being able to hold and raise those babies as any white woman in this country. Unfortunately, right now, we can't say that. And the third disclosure is that we are addressing racial disparities in maternal health. We're going to spend a lot of time focusing this morning on disparities vis-a-vis Black women. But as you'll see over and over again, the burden is the greatest when it comes to Black women. But this is most definitely not to say that there aren't other areas of disparities, and that there are not other groups of women who disproportionately shoulder the burden of these disparities. And this isn't to say that they're any less important. I truly and deeply believe that when we address any implicit bias, including racism, we're improving outcomes for all women and babies. So our objectives for today, we're going to look at the data around maternal morbidity and mortality. We're not going to spend a huge amount of time on this because I think we've seen this before. We're going to talk about racial disparities in maternal morbidity and mortality. We're going to spend more of our time working to understand the causes, both outdated and updated understandings. And then most importantly, perhaps we're going to spend some time outlining a path forward, moving from a place where I have been, and I think many people are, of feeling helpless and powerless, to moving out of that place into a place of agency and a place from which we're capable of action. So first, a look at maternal morbidity and mortality from a global perspective. Globally, you can see morbidity and mortality are falling, and that we, the United States, which is the red line, are an outlier. So in well-resourced countries around the world, maternal morbidity and mortality is falling, but in the United States, it's rising. And this is despite how much we spend on healthcare in this country. So before we launch into morbidity and mortality as it relates to race, let's take a minute and talk about what race is and what race isn't. And this 2 minutes that I'm going to spend here certainly do not do this topic justice. People spend entire careers on this topic, but I didn't feel like we could broach the subject without putting race in its context. So I'm going to credit my colleague Liza Winston with the content of this slide. We need to understand that the meaning of race is constantly shifting and being contested. Its uses have more to do with society and power relations, economic arrangements, social norms, and maintaining power and privilege than it does with biologic differences among human beings, such as the color of their skin, which is what we're talking about when we're talking about race. Race is a way of categorizing groups of people and is usually used to justify and or maintain inequities, inequalities, and oppressive practices. And while concepts of race have varied and changed over time, often in response to resistance and struggle and what the political agenda or social agenda of the time is, race remains at the center stage of US history. So this isn't to say, this is not the same as being colorblind and saying that race does not matter. Race very much matters in this country because from its very beginnings, race has been part of the fabric of the way this country has functioned politically and socially. So now on to racial disparities. Racial disparities were first described, some would say, in 1985 in the Heckler Report. The Secretary of Health and Human Services, Margaret Heckler, published a report, the Secretary's Task Force on Black and Minority Health. And since that time, the disparities that were described in that report persist. The CDC in that report defined it as a particular type of health difference that's closely linked with social, economic, and/or environmental disadvantage. They adversely affect groups of people who systemically experience greater obstacles to health based on their race or ethnic group. Now we're going to describe some of these disparities. So, as many of us, I think, know, it can be dangerous to be Black in the US. This is a look at life expectancy of Black non-Hispanic, white non-Hispanic, Hispanic, Latino people in the US. And you can see that the life expectancy for Black men and Black women is lower than that of their counterparts. And hypertension is just one small example of the disparities that Black and brown people experience. So for Black men and Black women, rates of hypertension are higher than for their counterparts of other ethnicities and races. It can also be dangerous to be a Black woman in the US. So this is a look at cervical cancer by race and ethnicity. The first thing you can see is that Black and Hispanic women experience higher rates of cervical cancer than white women. The other thing that you notice is that while Black women have a lower rate of cervical cancer than Hispanic women, they have a higher mortality rate. And in these studies, and most of the studies and data I'm going to talk about, they've been controlled for factors such as poverty, economic, and socioeconomic factors. We can follow this trend to many GYN diagnoses for breast cancer. Black women have a lower but a higher mortality. Someone's not on mute. In endometrial cancer, Black women have a 5-year mortality ratio of 30% compared to 20%. And it's not just attributable to later stage of diagnosis, because studies have found that Black women are also less likely to get guideline concordant care. Black women have the worst survival rate when it comes to ovarian cancer. In terms of ectopic, which I alluded to earlier, Black and Hispanic women are 20% less likely to have tube conserving surgeries. This is nationally. And when we look at hysterectomy data, Black women are more likely to have open surgeries, more likely to have surgical complications. And when they look at subsets of women, Black women, and all women who have laparoscopic surgeries, they're still more likely to experience complications. So this is what you're looking at right now is a list of most dangerous jobs in the US as of 2016. This is from the Bureau of Labor. And I took this concept from a midwife, Diana Giles, who presented at a midwifery conference. She works with the Centers for Medicare and Medicaid Innovation Strong Start for Mothers and Newborn Project, looking at preterm birth, low birth weight, and the cost of care, and looking at those things over different models of care. And she had the concept of placing becoming a Black mother amongst the most dangerous jobs in America. I think these kinds of images are important to put things into perspectives of other things that we think about when we spend a lot of time listening to statistics in and of themselves. It's easy to remember that they represent people and lives. What you're looking at now is pregnancy-related mortality rates. per 100,000 live births in the US. This is data from the CDC. Black women are 4 times more likely to die in pregnancy than white women. These rates are on the rise, as we saw in that first slide where we saw the United States as an outlier globally. And the biggest increases that we're seeing are in Black women. So, for example, between 2008 and 2014, Black women saw an increase in pregnancy-related death of 9.6 deaths per 100,000, compared to an increase of 4.4 deaths per 100,000 for white women. And for every maternal mortality, we know that behind that are many near misses, which we call severe maternal morbidity. And we're going to talk about that more, but we know that severe maternal morbidity, or SMM, is also on the rise, with Black women shouldering, again, more than their fair share of that burden. We know that there are other disparities in obstetrics, for example, higher C-section rates for non-Hispanic Black women and higher primary C-section rates for non-Hispanic Black women. This is according to the CDC. It can also be dangerous to be born to a Black mother in the United States. So you can see here that no matter what gestational age range you're looking at, Black women experience more preterm births. And when you add to this studies and information, what we know about administration of corticosteroids, it leads us to statistics like this. So infant mortality is higher for Black non-Hispanic women in the United States. In a recent white paper called Antenatal Corticosteroids Administration, they looked at steroid administration of 183,000 women in the US with preterm birth between 23 and 24 weeks using a CDC database, and found differences in rates of administration between non-Hispanic white women who got steroids 44.5% of the time, non-Hispanic Black women who got it about 38% of the time, and Hispanic women who received steroids about 37% of the time. So again, like I said, when we're looking at statistics over and over again, we get a little bit of fatigue and forget that it represents actual people and actual lives. So Greenwood and colleagues in a recent study called Physician-Patient Racial Concordance and Disparities in Birthing Mortality for Newborns looked at 1.8 million hospital births in Florida between 1992 and 2015. And one of the things that they did in the study, it wasn't the point of the study, is they extrapolated what the number of deaths would be for Black babies were the rate of death comparable to that of white babies. So if the mortality rate for Black babies in the United States were the same as for white babies, there would be about 3,000 fewer deaths of Black babies annually. So now let's take a look at disparities in Massachusetts. It's easy to look at statistics and hope they don't apply to you, but you'll see as we travel from the macro to the micro that they apply to the care that we're providing as well. In Massachusetts, maternal mortality for Black women is about 4 times higher than it is for white women. Infant mortality, we see similar trends, double the rates for Black women in Massachusetts. Preterm birth rate higher for Black women than for white women. And late to no prenatal care. Black women are about 4 times more likely to receive less or worse prenatal care. And we'll come back to that later as one of the things that I think we have an opportunity to focus on. Traveling down to the Springfield level, this is the Springfield Health Equity Report, a copy of which is going to be posted on our new Racial Disparities and Health Equity bulletin board on the ObGyn corridor. It's currently under construction. And this report looks at various things, not just obstetric related. And we see that there are disparities in asthma, COPD, obesity, cardiovascular disease, diabetes throughout the city of Springfield. In many of these areas, the Latinx community is faring worse than the Black community. So what you're looking at now is the premature mortality rate in the city of Springfield, and I'll blow that up for you. Green is good, yellow is not so good, and red is worse. And you can see that around Springfield, the colors start to change pretty consistently. So disparities in Springfield. You can see that in terms of preterm births, Massachusetts is the dotted line, and in all groups, we are doing worse than the state average, with Black women being the top yellow line there. In this instance, top is not good. Looking at percent of low birth weight, you see a similar phenomenon for Black women in Springfield. Also, Latina women are faring worse than white women in Springfield. In terms of infant mortality, you can see that Springfield is doing worse than the state is doing in general, and that for Black women in Springfield, the rate of infant mortality is about 3 times as high as it is for white and Latino. If we look at prenatal care in the state of Massachusetts, and this is the percent of women receiving adequate prenatal care, so higher is better here. We see that Black women, like the state and like the national level, are not receiving adequate prenatal care at the same rates as their white and Latina counterparts. And thankfully, as Heather alluded to earlier, we now have some Baystate Department of ObGyn level data. Dr. Andrew Healy presented this last week at Quality M&M. And while we don't have complete data comparable to the other data we looked at, what we do have is useful. So this is from the AEIX collaborative that we're participating in. And if you look at the portion that represents Black women, the darkest line you're seeing is the percentage of births that is represented here. So Black women represent 12% of the births in 12% of the births in Massachusetts. In the Department of ObGyn. The middle blue line is percentage of SMM, or what we'll call SMM 21. So SMM 21 includes all drivers, including postpartum, including transfusion. And you can see that Black women shoulder more of a burden than their representation of SMM 21. The light blue line is SMM 20. So when we exclude transfusion from the calculations, they shoulder a greater burden still. So if we did not have disparities within our department in SMM, then those lines would all be comparable. This is looking at that same data based on ethnicity, Hispanic or Latino, and non-Hispanic or Latino. And you can see again here that there is a discrepancy between the percentage of births and the burden of SMM 20 and SMM 21. So instead of reinventing the wheel, Dr. Healy gave me his summary slides from last week about SMM at Baystate. So in summation, SMM rates for white and Hispanic patients were relatively steady over time, whereas rates among Black and other/multiple race ethnicity patients were more variable. Fortunately, they seem to be on the decline recently. We do know that for SMM20, again, that's contributors to SMM not including transfusion, Black patients experience rates greater than 3 times that of their white counterparts. Hispanic patients had rates nearly 2.5 times as our white patients. And other/multiple race ethnicity patients experience race over 3 times as high as white patients. So now we're going to transition into talking about why these disparities exist. It's mostly a story of yes and. In some ways, we've greatly overcomplicated the explanations for racial disparities, and it's really quite simple. So first, we're going to go through some of the traditional explanations. So, is it poverty? We know that because of institutional sexism, and racism, women are more likely to live in poverty and Black women are more likely still. Numerous studies show, however, that after controlling for education and socioeconomic status, African American women remain at higher risk for maternal and infant mortality. One study showed that after controlling for income, gestational age, and maternal age and health status, the odds of dying from pregnancy or delivery complications were almost 3 times as high for African American women than they were for non-Hispanic white women. So even when we control for poverty and income level, these disparities do not go away. Is it access to care? We know that because of institutional racism and perhaps other factors, African American women have less access to care overall in the United States. They have less access to prenatal care. But here you can see that Black women are faring better than our Hispanic and Latino brothers and sisters in terms of access to care. Yet, as you saw, when we look at morbidity and mortality for moms and babies, Black women are faring worse, even though worse than our Hispanic and Latino brothers and sisters. So this brings up another question that we're going to talk about briefly again later. What is it about our care model that's not working very clearly not working consistently for groups of women? Is it education? We know, again, because of institutional racism, Black women are less likely than white women in the United States to have a high school education. But again, they're more likely than Hispanic women who have better outcomes than Black women when it comes to maternal and infant mortality. And this, I think, is one of the most interesting phenomenon of all. Education does not eliminate the disparities, and it is not protective for Black women. So this is looking at pregnancy-related mortality ratio. So you can see here, Black women are represented by the dark purple line, that Black women with a less than high school education fare better than Black women with high school, some college, and college graduates. If you look at infant mortality, college-educated Black women have the same risk as white women with less than a high school education. So the answer is not education, and education actually seems to be a particularly troublesome phenomenon. So this is me. I'm at the highest risk, despite my income, despite my education, despite my access to prenatal care. This is me. I'm at highest risk. So there's something more. There's something else going on here. So is it the other markers of health that we typically think about and talk about? Obesity, smoking, mental health. I'm sure as a group we could come up with a more comprehensive list. A study from the New York City Department of Health and Mental Hygiene showed that African American women of normal weight were still at higher risk of dying in the perinatal period than non-African American obese women. A related study comparing infant mortality rates of obese African American and non-Hispanic white mothers showed that non-Hispanic white women experienced uniformly lower risk. So why? If it's not poverty, if it's not access to prenatal care or adequacy of prenatal care, if it's not education, what is it? No matter how you look at it, Black women and babies are at risk. This is a look by state, looking at states where pregnancy-related mortality is better and Black women are still doing worse. If you look at it by age, Black women are still doing worse. So if we can't explain it with poverty, education, access to care, other social determinants of health, what is causing these disparities? And the bottom line is that it's racism. It is racism, not race, that's the driving force behind these disparities. Racism, not race. So this is a graphic I came up with, which is my attempt to put it all together in the context of the big picture. And we're going to break down several of these parts. So institutional racism in housing, education, environment, employment, violence, politics, healthcare contributes to suboptimal care, in addition to institutional racism contributing directly through to suboptimal care. The institutional racism, as well as lived discrimination, including racist science, which we'll talk about in a moment, and epigenetics, contribute to allostatic load, which place women, Black women, brown women, at risk for morbidity. And morbidity is the precursor of mortality. Again, not forgetting about the SMM, the severe maternal mortality, for which we see there are many of those behind or underscoring every maternal death we experience. And over there on the left-hand side, one of the most important things for our talk today, because it's the place that we stand to have the most impact, is individual racism and unconscious bias and how that contributes to suboptimal care for the patients we care for. So institutional racism exists in several forms. In every form, healthcare is just one of them, obviously one that concerns us greatly. You can define it in many ways, but essentially one of the main components is differential access to resources and opportunities. Policies, institutional practices, cultural representations that perpetuate race inequity. And in this country, we've had hundreds of years of racism and systemic barriers that contribute to the conditions that we now see today in terms of many things, but what we're here to talk about today, racial disparities in maternal health. Allostatic load and weathering. So racism is one of the things that contributes to allostatic load. Allostasis is the process by which the body and systems return to baseline after a stressful stimulus. So when the body's subjected to chronic, repeated stressful stimulus, the stress point is altered. And allostatic load is what we're calling the difference between the normal set point and the new set point after the chronic stress. So we can think of it in several ways. We can think of it as cumulative. So for example, during pregnancy, chronically elevated levels of cortisol lead to immune suppression, increasing women's risk of perinatal infections and leading to other complications. We can also think of it as an early programming pathway. Seeds being sown early, exposure to risk during sensitive developmental periods in utero early in life can affect a woman's health later on. For example, research linking maternal depression and anxiety to higher risk of obesity and diabetes among offspring. So this is the explanation for why education is not protective, but potentially more damaging for Black women with higher education. Black women with higher education spend more time in potentially stressful situations, being exposed to the toxicity of racism in all its forms, and thereby potentially bringing a higher allostatic load to every experience in their lives. Epigenetics is the feedback loop between genes and the environment, and racism certainly contributes to epigenetics. I like this example because of the colors. It can help you trace the effects from generation to generation. I don't like the example because it's about smoking, and we tend to be very judgmental about smoking. So substitute poor nutrition, chronic stress, stress from racism, depression, and anxiety. So you can see in the first picture, the environmental stimulus impacting the red baby. The red baby is then a grown woman and begins her pregnancy more obese than her mom, thereby impacting the blue baby, who in this third generation is in turn more obese. So racist science in medicine, again, this is one of those areas where I can barely do it justice, but can't talk about this topic without mentioning it. So we can't understand the state of affairs without understanding the backdrop. So in Washington's book, Medical Apartheid, she spells out very clearly the collusion between the medical establishment and slavery. Very early on in this country, the medical establishment and physicians were brought in to attest to the health of slaves so that they could be treated inhumanely. This bore the development of a racist science, so false beliefs that, for example, Blacks have a sensitive nervous system, decreased ability to feel pain, skulls, thicker blood, stronger immune systems, all in the name of justifying subhuman treatment of Black people and slaves. Medical aggression against Black and brown bodies has been well documented throughout this country's history. Many medical schools in early times boasted being located in inner cities and having easier access to Black and brown bodies for experimentation. GYN surgeries, many of the foundational techniques, or especially fistula and C-section surgeries, were enacted by women and many times without anesthesia. And we all have heard about, someone's not on mute, the coercion of Black and brown women around contraception, the Mississippi appendectomy, or women going in for surgery and being sterilized without their consent. Unfortunately, not a thing of the past. Coercion of vulnerable women is alive and well, as we've seen in the headlines over the last week with the allegations of ICE and unwanted sterilization procedures of women in their custody. So here we are left with this picture, this big picture, mostly things over which we have little purview, things outside of our immediate locus of control. But one major thing that we do have within our control is unconscious bias and racism. The ways in which we feel and react differently to people based on our assumptions about them. This is both systemic and personal, and it's time to stop sitting in our corners, feeling like we're doing our best for each individual patient who sits in front of us. We need to look at the big picture. We need to look at the forest for the trees and acknowledge the disparities that exist within the care system that we participate in, the care that we create, and the care that we deliver. So just a quick tutorial on what is unconscious bias. It's actually a fascinating topic, and I think it's key to understanding and coming closer to a place where we can examine our biases and racism without blame. So in this example, if you were to cover your left eye and stare at the plus sign and come closer, the circle disappears. So we have a literal blind spot in our retina. In this image, if you do the same thing, cover your left eye, stare at the plus sign and move closer, the black circle will turn yellow. So our mind actually tries to help us out by filling in information that we don't have with, in this case, false information. And further, in this circle, in this example, if you do the same, the yellow circle on the right actually turns red. So our brains are programmed to fill in information that we don't have. And what kind of information that is impacts the care that we deliver to patients. So in the book Blind Spot, which is a really great read, they talk about this blind spot. We're all human. We all have this blind spot. It's actually biological. It's part of the human condition. Our brains are designed to organize the world that we live in, to place things in categories quickly in order to maintain safety. So in a system where we lived as clans and people who were like you were safe and people who were different than you were potentially more dangerous, this was a really useful and a really important feature. Having been raised in this culture, as most of us were, we have biases. It's a fact. It's part of the human condition. And we have biases based on race. To deny that we have biases based on race is to say that one of our brains works completely differently from every other brain on the planet. So we know that bias and racism in medicine is alive and well. There have been many emergency room studies that document longer wait times for Black and brown people, lower triage scores for Black and brown people of similar condition, lower odds of testing, including things like radiologic testing. Pain is also one of the areas that's been fairly well studied. And these studies span all settings: primary care, cancer treatment, emergency room, children and adults. Studies find fairly consistently that Black and brown people are less likely to receive analgesia for pain. And then that raises the question, is it a matter of overtreatment of white people or undertreatment of Black and brown people? And there's actually evidence of both. One study that was really interesting looked at false beliefs about health and race. So, for example, those beliefs that I talked about earlier about Blacks having being less sensitive to pain, having thicker skin, those things, and found that many people in the lay public believe those things, and many medical trainees, which is who they were looking at in this study, believe those same things. And further, for the medical trainees who believed, the more beliefs they had, the more likely they were to underestimate the pain and undertreat the pain of Black and brown people. There have also been some specific OB studies looking at pain management in the postpartum setting. One study found that non-white women had fewer postpartum pain assessments and less medication despite similar pain scores, both at 0 to 24 and 24 to 28 hours postpartum. And studies looking at postpartum pain management in general found similar things. So here we are with this complex picture that's been hundreds of years in the making, many of the pieces of it outside of our purview. So where does that lead us? Where do we go from here? So we start by acknowledging that we're not immune, we're not, and without blame, with humility and compassion, we acknowledge our bias, we acknowledge our racism, both personal and collective, and we make a decision to start. We don't need all the answers, we're not going to have all the answers, but that's not a reason not to start. The time has come. Never doubt that a small group of thoughtful, committed people can change the world. Indeed, it's the only thing that has. Margaret Mead said this. No one's going to do this for us. Since we have acknowledged and tracked racial disparities in the US, they have persisted. We didn't come to this place in a couple of decades or even a couple hundred years. Centuries of racism got us to this place, and only by acknowledging our racism and pushing through are we going to start seeing gains. So here's the framework that I have in mind. This is from Dr. Karen Scott in her paper, Redesigning Perinatal Quality Improvements, Community-Driven Measures, Meanings, and Methods. So she talks about naming the phenomenon, defining the phenomenon, and then proposing methods to measure, examine, and modify. In our department, in our institution, we need to do that in the three following areas: clinical, structural, and cultural. So naming the phenomenon. That's a big part of what we're doing here today. We need a collective understanding that racism, not race, is the cause of racial disparities in maternal and infant health. Defining the phenomenon clinically, this is the part that we're really good at here. We have really great clinical minds, and we're really good at developing evidence-based protocols. So what are the things driving morbidity, mortality, and SMM in our institution? We're looking at C-sections and NTSB rates. We're looking at postpartum hemorrhage. What are the things that are driving disparities in gynecology in our institution? We don't have those answers yet. These are some of the things that we find if we look at the national literature. We're measuring, examining, and modifying. So the AIM, PIN-QUIN, DPH work that Dr. Healy presented last week, the AEIX work, some of which we looked at earlier today, and our structure. So what's working and what's not working about our structure? So for example, the V2 and LDRP model. Is it time to look at a low-risk birth center and how that could positively impact racial disparities? An early labor lounge. All of our guidelines and protocols, and looking at whether they provide increased access or limit access to care. So for example, a couple of weeks ago, the change in policy that we were going to start asking visitors for IDs. What kind of impact does that have on access to care for our patients? The structure of our care, so our prenatal care model. Are we providing prenatal care in the ways that patients need? This pandemic has taught us that we are much more capable of thinking outside the box than we ever thought we were. Necessity is the mother of invention. So do we need to revisit that model of prenatal care? The department is looking into baby scripts, which is partially a remote delivery system, and then diversity of our staff. This gets its very own slide because it's so very important. So we know that concordance has an impact on attitudes and outcomes. In a study I mentioned earlier, Greenwood et al. This year, in a study called Physician-Related Racial Concordance and Disparities in Birthing Mortality for Newborns, looked at 1.8 million hospital births in Florida between 1992 and 2015. And they found some really troubling findings, which was that Black babies' mortality rate was impacted by the race of the physician caring for them. So this is newborns in hospital care. So unfortunately, we know that concordance can have an impact. I'm sure there are lots of components to that care. They did filter and control for lots of things like acuity of patients and things like that. And interestingly, the discrepancy didn't extend to birthing women. So structurally, with every decision we make, we need to think about the impact on our most vulnerable. We need to look at all of our policies. So when we look at every policy and we think about equality, each of these people has the same box, but that presumes that they have the same starting place, which clearly they don't. If we move to an equity perspective, we give everyone not the tools that they need, not giving everyone the same tools, because we acknowledge that people have started in different places. But what if we change our perspective and start thinking about justice? Start thinking about what the real problem is, which is the fence. We make so many assumptions about the basic problem, the basic barrier being unchangeable. I think we're in a place now where our minds are more flexible and our system is more flexible, that we need to start asking the question about the barrier itself and what we can do to remove the barrier itself. In terms of our own individual journeys, we need to be the change we want to see in the world. We need to be willing to do the work personally, turn our lenses inward, examine our interactions with ourselves, with our colleagues, with our patients. This is a really good article that'll be posted on the bulletin board, Racist Like Me, and it encourages people to think about bias as part of the human condition. We are human, therefore we have bias, but to acknowledge that it's a treatable condition. I highly recommend the implicit association test, which you can find on this website. There are many of them on all of these subjects here, and in the privacy of your own home, you can take these tests and reflect on how bias may come into your life and the care that you're providing. There's lots of amazing reading, and the department is purchasing 4 lending libraries that are going to exist in the chair's office, in the physician lounge on labor and delivery, and the nurse's lounge in labor and delivery, and one other place. So you're going to have access to these books and more that you can borrow. In terms of our group culture, we're looking into bias training for all of us. I don't know what that's going to look like in this COVID environment. And then we need more opportunities to engage. So discussions with one another, book clubs, film viewings and conversations, and then Baystate's initiative, Elevating Dignity, gives us an opportunity to contribute to these conversations in the larger institution. We also need to think about our interactions with patients. So what does it look like if we place the blame where it is on racism, not Black bodies? Stop blaming Black women's bodies for what is caused by racism, not race. Women come to us knowing that they are at increased risk. Women are scared. When women show up in We2 in the middle of the night not calling, it's because the media tells them they're not going to be listened to. And in a lot of instances, they are right. Their concerns are dismissed, their concerns are passed over, and women are dying. So when someone presents to you without having called in the middle of the night, think about the backdrop of what her life is like and what she's hearing and why she's coming to you the way that she is. So part of our path forward is the formation of a steering committee that's meant to do just that, to steer, to pull together our efforts around racial disparities, to make sure we're addressing all of the areas. So this is a group that's going to look at the big picture for us. As you can see, we have very wide representation. We'll have representation from gynecology as well. I'd like to have representation from our outpatient settings, and ultimately representation from a consumer as well, because I'm not interested in a process that is from the top down, telling Black women and brown women what they need. So my vision for us is that we create a culture where we can use the word racism and racist again, that it's not a personal slur, but a description of behaviors and patterns of behaviors and patterns of thinking that lead to deleterious effects for our patients. That we come to a place where we can respectfully and compassionately call one another on our racist and other biased behaviors. That, for example, we have case reviews where we can ask ourselves open and honestly and ask one another, Did bias potentially play a role here? I'd like to see racial disparities elevated so that we have a dashboard, so that we're reporting on this on a regular basis in our quality initiatives. I'd like to be in a place where we're centering women's experiences, where we treat every incident where any woman, and especially Black and Brown women, feel disrespected by our institution as a serious event. And further, for these girls and all Black and Brown girls, I want them to have faith that they'll be as safe in pregnancy as anyone, that they'll be given all the choices, all the options, all the guideline concordant care, that they'll feel seen and feel heard, that they won't have to ask, as a recent patient in our practice did, what can you offer me as a Black woman to reassure me I'll be safe? That if they have babies, it won't matter the color of their doctor's skin in their baby's outcome. We are leaving women and babies behind. That's not why I came here. I don't think that's why any of you came here. It's time to stop being statistical voyeurs. We can do better. We must do better. We will do better. We're not going to get there overnight. We're not even going to get there over a decade, but we're certainly not going to get there by ignoring or not seeing the forest for the trees. I'd like to extend my thanks and appreciation for Baystate Midwifery and Women's Health, who's listened to this content so very many times, for Emily Jackson, Sharon Weintraub, Liza Winston, and Suki for all of their research help, for Sharon Holly for mentoring me and pushing me to follow my passions, for Heather and Andrew being willing to engage with me, set this as a priority for the department, and for all of you, the compassionate, amazing team that I work with and that I'm honored to share this journey with. So as Maya Angelou said, do the best you can until you know better, and then when you know better, do better. So it's time to do better. As President Barack Obama said, we are the ones we've been waiting for. No one's going to do this for us. Thank you. And I'm sorry that that went so very long, and it's 9 o'clock, so I know most people probably have to run off to their various clinical duties, but I can stick around for a little bit if people have questions or want to chat. Thank you very much.
Tanya, it's David Catan. I wanted to thank you for presenting such an important topic, and I'm really glad. I think that for someone like myself who is male, not a minority, I think part of my challenge personally is to try to wrap my head around, what concrete steps we can take to battle systemic racism. And so I'm glad that we're forming a group to kind of to guide us in that process, because I think that's one thing that hampers my response. It's hard to say, okay, these are the concrete things I can do in my life.
Thank you. Yeah, I think that's a big stumbling block, or something that holds a lot of us back, is not knowing where to start. But I think a good place is for all of us examining and being honest and compassionate with ourselves about our own personal biases.
Yeah, Tanya, this is Susan. Great presentation. And
Susan.
Hi. I'm most impressed by the steering committee you're putting together and working towards kind of a long-term solutions on a lot of different levels. I think that's really, really going to help. So thanks for pulling all that together. That's huge. And I think as a department, we will benefit from it incredibly.
I think one of the biggest things you've taught me, Susan, in all of our years of working together and you mentoring me, was that sometimes just by calling attention to a particular topic, you make changes and impact. Well, unless anyone else has any comments or questions, I think we're going to end this. I'm pretty certain you all know how to find me. If you have any questions or want to chat. Thank you.